Hi, this is Dr. Stefan from interstitiallungdisease.info. In this video, I'd like to discuss about this really important topic, and it's something that if you are dealing with interstitial lung disease in your diagnosis, in cases of IPF, you might run into this situation when autoimmune abnormalities are present. So how do you diagnose IPF when autoimmune abnormalities are present on the autoimmune screen you are doing as part of the diagnostic workup for IPF? This is a guide for non-experts, and I also add some of my own questions to be answered in the future, because I'm also not certain in some situations. So hopefully this will be helpful to better understand how to approach these situations, which are not really rare. You will come across this at some point in your practice. Before I begin, the information in this presentation does not constitute medical advice, and if you are a health professional, please use your own judgment when treating patients under your care, and do not only rely on this presentation or other information you find online. You are ultimately responsible for decisions and recommendations you make regarding patient care. That being said, let's talk a little bit about why do we screen for autoimmunity. So autoimmune abnormalities in IPF. IPF is a diagnosis of exclusion. I did mention this in previous videos, and an autoimmune screening panel usually is done as part of the diagnostic workup. We want to rule out any connective tissue disease being present, and this is usually negative. In a patient with a typical presentation of IPF, we don't find any autoimmune abnormalities, and if that's the case, it is definitely a strong argument in favor of a diagnosis of IPF. So when autoimmune screening is negative, that fits well with the diagnosis of idiopathic pulmonary fibrosis. However, we have many, I would say, atypical IPF presentations. There's not always a case like in a textbook of IPF. Some abnormalities can be present when screening for autoantibodies. What do we do in this case? I have examples from my practice, and these can include, for example, I've seen patients who have had positive SSA and SSA52 antibodies, which are suggestive of Sjogren's disease, or patients with mildly positive anti-CCP antibodies, which can be a feature of rheumatoid arthritis. And then mildly positive myositis-associated autoantibodies such as Jo1 and PL7. I've seen these in my practice. And however, these patients do not have any symptoms or features that would suggest a connective tissue disease is present and are otherwise the right age for a diagnosis of IPF, and they're usually elderly over the age of 65. So what do we do in these situations? In my practice, in our practice, which may vary basically, depending on where you are in the world, we have to adapt to local policies as well in some instances. But what we would do, we would request a rheumatology opinion in these situations. This is just to confirm that no connective tissue disease is indeed present. We want to have an expert opinion regarding any potential CTD features. And then we can potentially also perform a bronchoscopy with a bronchoalveolar lavage and differential cell count to rule out any lung inflammation. So if patients do not have high lymphocytes and they have a relatively normal differential cell count on the bronchoalveolar lavage, again, it's an argument in favor of disregarding these autoimmune abnormalities. The other thing we would do is closely monitor for emerging connective tissue disease over time. So we need to be careful because lung involvement can sometimes occur before other systemic features are present. So we know this is the case in rheumatoid arthritis. Sometimes the lung involvement precedes joint involvement. So patients may actually have rheumatoid lung disease before they actually develop the joint disease. So this is an argument in favor of monitoring closely and having a low threshold to change during the diagnosis if features change in the presentation of our patient. Lung biopsy is a topic of debate in many instances, and some clinicians are more aggressive with performing lung biopsies. We don't really follow that, so we think that lung biopsy is very rarely required if everything else is in favor of an IPF diagnosis. So because of the risks associated with lung biopsy, especially in patients who potentially have advanced lung impairment, we don't really consider that to be needed if everything else is in favor. So the other thing we would do is maybe, because of the regulations surrounding antifibrotic therapy prescription, we would make a pragmatic decision in the best interest of our patients. So how would they otherwise be eligible for antifibrotic treatment if a diagnosis of IPF cannot be made? So that depends on local access to treatment. In some countries, this is a bit more liberal. You can prescribe antifibrotics easier, but in some jurisdictions, unless you have the indication of idiopathic pulmonary fibrosis, you your patient will not be able to access these therapies. They will not be available to them reimbursed. So that's something that we need to take into consideration to give our patients the best possible options. And also, we may consider in some cases, if we do think that the autoimmune features that we've seen on the autoimmune panel can be relevant, we may consider introducing a low dose of an anti-inflammatory treatment in addition to the antifibrotics, such as prednisolone 10 milligram equivalent. And we closely monitor if we notice any kind of positive response. But of course, if there is no benefit shown, if our patient is progressing as before, we probably wean off the steroids if no benefit is noticed because of the potential side effects and adverse effects of corticosteroids. So this is basically what we would consider doing in these situations to try to move forward with a working diagnosis of IPF, but to closely monitor. And then a level of uncertainty will always remain. And this is something I struggle with personally. I worry about these things, and I advocate a close follow-up for these patients because I cannot be sure that the autoantibodies are not playing a role in the fibrotic process. It's something we won't know. And then the other thing is, if we only treat with antifibrotics, are we missing an opportunity to stabilize the condition with anti-inflammatory therapies? This is a question that always plagues me. And then I'm not sure of the long-term prognosis because maybe these patients will not progress at the same rate as a typical IPF case. And we may need to have some conversations with our patients regarding long-term outlook. And then the final thing would be, always, I would consider if there is a familial component present, a genetic predisposition, because we know that patients with IPF, with autoimmune abnormalities, have sometimes been, these cases have been associated with a genetic predisposition. So I would always ask the patient in these situations whether they have any other family members, any relatives with fibrotic lung disease or any other rare or unusual conditions, maybe many cancers in the family, myelodysplasia, early menopause, things that would make me think that there could be a genetic predisposition. So this would then constitute a case of familial interstitial pneumonia rather than an IPF, purely IPF case. However, probably we would need to retain the label of IPF in order to be able to access the treatment, but then keep in mind the implications of the familial predisposition. So I hope these little points that I've included in this presentation are helpful for you. And if you have any questions, do leave them in the comment section below or reach out on the YouTube channel, and I'll try to create more content that's helpful for you. Thank you very much for watching, and all the best.